Okay, so the final speaker today, let me just bring this up, I went out of it. Final speaker today is Francis Saunders, speaking on the topic of increasing access to autism assessments for children and young people and identifying the complex needs of neurodivergent individuals in a mental health context. And also just to add, there is a trigger warning for this session for mental illness, self-harm, suicide, eating disorders, body hatred and fat phobia. Okay, lovely to meet you. Thank you so much.
It's great to be here and so amazing to hear authors of some very precious books on my bookshelf, so it was great to hear the previous speakers. I'm presenting you today a model of building workforce capacity in child and adolescent mental health services and related health service systems to provide increased access to free public autism assessments. Since 2020, this model has assisted us in delivering an additional 500 assessments outside of existing specialist autism assessment teams within mental health. Since this initial project, we have received further funding for an additional 1,600 child and adolescent youth assessments to continue this work. And in 2024, we received funding for the establishment of adult autism assessment teams, providing another 200 assessments with funding assured for another 12 months. In total, this funding equates to around 2,500 additional autism assessments in the last 5 years. The focus of this talk is our initial project of 500 assessments and how building workforce capacity around autism in child and youth mental health services has been the foundation of our success in increasing access to services. Our training centre is part of the Department of Psychiatry at the University of Melbourne and is funded by the Health Department. Our centre provides free and subsidised autism professional development to Victorian mental health clinicians at low cost. Free to Victorian mental health clinicians and low-cost training to other health professionals. For context, this work occurred in the state of Victoria, which has a similar population to Ireland, around 6.7 million, but is nearly 3 times the size. Throughout Australia, access to services is challenging due to the huge distances people have to travel to find services and skilled clinicians. As background to this work, it's important to acknowledge that the development of this model started with funding from the 2009 Victorian Autism State Plan, where many different government departments, education, health, mental health, clinicians and autism advocacy groups came together to develop a state plan. This model of building workforce capacity has 3 main elements that have been essential to its success. The first is, of course, that money is essential. We can do a lot with a little, we don't need a lot of money. So a small government grant through the first Autism State Plan in 2009 enabled employment of a part-time statewide autism coordinator, which is the role that I currently hold, to develop training and to support autism coordinators in each of the 14 child and adolescent or CAM services covering all geographical regions of the state of Victoria. The second element is training. Training is essential to develop knowledge. And the third element is that this needs to be supported by key skilled clinical staff. Lead autism clinicians in each service are essential to mentor and support skill development in other clinicians in the multidisciplinary teams and to support communities of practice outside of the mental health services. These roles were also recurrently funded by the Autism State Plan. So a word about training, the impact and the reach of the training. So the first graph shows the numbers and how training has increased over the past 10 years by tenfold. Since the COVID pandemic, most of our training transitioned to being online or either live webinars or on demand, which made training easily accessible to everyone. And now 25% of our attendees are from states outside of Victoria. And you can see also from the map of Australia, and I'm not sure that the colours show up well, but the density of colour shows as an indication of where people are coming from. But you can see that people all over Australia are now able to access training. So let's look at service delivery. This map represents the reach of the first project that we did, assessment project, which delivered an additional 500 autism assessments through mental health services working with partner organisations. We have seen over time that the impact of providing autism training to mental health clinicians, combined with the support of lead autism clinicians in services, has developed the capacity of our public mental health services to deliver more assessments. And this is what we've based our additional assessment models on. 10 years ago, these services were completing, 200, 300, 400 assessments a year across Victoria, and now regularly completing an 800 plus assessments across the state, with little increase in EFT. Our Victorian Mental Health Services provide assessments for those children and young people presenting with co-occurring mental health conditions and a range of other complexities. So, back to the model of workforce development. Oh, I think here we go. I'll slide behind. So back to the model of workforce development. Of course, knowledge is built through training. So knowledge is essential and high quality training is essential. We offer 3 levels of training. We offer core training that every mental health professional should undertake and do undertake within our services so that they're able to understand, identify autism and adapt their practice. We offer skill development around understanding of co-occurring conditions such as ADHD, eating disorders, and the list goes on. We offer advanced assessment training, and this is specifically for multidisciplinary staff providing diagnostic assessments. So skills are developed through clinically focused training and the opportunity to learn through observation and practice. New clinicians have the opportunity to consult with autism coordinators or leads in their service and are able to observe assessments and complete these assessments in a supportive way. So they're learning through observing and also supported doing. And this is the model that we've applied to our assessment project work. Mentoring by these clinicians or expert autism coordinators develops the clinician's self-confidence and independence in assessing their own clients. And lastly, it's important that bringing the network of these clinical experts or clinical leads together. It promotes sharing of resources, benchmarking of clinical practice and innovation, and collation of information that can be communicated to government. So this model just shows you how the importance of that conduit between government and these coordinators is through this statewide role that I hold. The Mindful Assessment and Capability Project was the first of several projects we've undertaken since 2020, and we've been funded to support expanded service delivery. The project commenced in 2020, which is of course COVID, and was supposed to take 2 years and took 3. We had long periods of lockdown in Victoria. These 500 assessments were completed in working with collaboration with other sectors, internal mental health partnerships and external partnerships to build capacity beyond the traditional assessment teams. Those who were offered assessments were between the ages of 2 and 25, and 71% of clients were diagnosed with autism or diagnosed as autistic. Uptake in regional areas was really high, so 60% of these assessments occurred outside of metropolitan areas. And what was interesting about that was these were the services that were more connected to the communities of practice and partnerships, and very easily able to build on these relationships to help these assessments happen externally. So the peak age of diagnosis, not surprisingly, coincided with times of transition and increased social demands such as transition to primary school and early high school. This slide represents how important it is to gather data around complexity of co-occurring conditions, and this has been really important to communicate with government. While these kinds of findings are well documented in the literature, we have found that this information has a bigger impact on managers of services when it's about their own clients and their own service. And this has also had a significant impact at a government level at a government level. Of these assessments, at least half had 1 to 2 co-occurring conditions, 16% had 3, 9% had 4 or more. The most commonly occurring mental health conditions, unsurprisingly, were anxiety, depression, eating disorders, and gender dysphoria. And in terms of the most common neurodevelopmental disorders, they were ADHD, language disorder, global developmental delay, and learning disabilities. So they're all DSM diagnoses, so apologies for the language. This probably is one of the key really important things, was understanding the complexity and being able to convey that to government. This really helps inform managers and government to understand why best practice assessments are costly, time-consuming, and it is critical that this work is done in a respectful and collaborative manner with our clients. So you can see that a third of the clients assessed experienced social, economic disadvantage, parent with a mental illness, exposure to trauma, and a quarter reported family violence. And of course, the individual complexity was also present, and again, really important for funders to understand. High rates of school refusals and suicidality. The key aspect of this project was to expand capacity of other workforce sectors to provide autism assessments. These assessments were completed in collaboration with internal partnerships within mental health and with clinicians outside the designated specialist autism team. There were also partnerships with external organisations which were frequent referrers to our mental health services, such as paediatricians, community health centres, Headspace, and other hospital departments. So finally, this is an example of what I understand is implementation science. The thing we wanted to do was increase clinicians' knowledge and understanding of autism and to provide comprehensive autism assessments. We did increase workforce capacity through training, mentorship, and strategic partnerships. We have demonstrated that it is possible to do a lot with a little. The project shows what can be achieved over time with a committed group of clinicians working in a coordinated way to provide more autism assessments. Engaging with policymakers and government has been essential, and the reporting of clinical data that's been gathered through these assessments that demonstrates the co-occurring conditions and the complexity experienced by these autistic individuals has positively influenced funding in the long term for increased autism assessments. And so these are grateful thanks to the people involved in this work. Thank you. Is there time for a question?
I think so as not to be the people who stand between you and your food. We'll maybe just take one question and just be mindful if you are leaving to leave silently. Do we have a question? Yes, we've one right here, the lady in the white.
Thank you for a very nice presentation, also from Australia. I'm just wondering, of the providers who you quoted doing the assessments, were any of them new to making a diagnosis of autism, or were they already existing diagnosticians? That's the first part. And the other part of my question is whether you considered engaging with primary health practitioners.
Yes, so in answer to your first question, they were all the partners were people who weren't normally engaged in giving a formal diagnosis. So it was a way to skill them up. Some were referrers who would refer into our service, so it was a way of partnering with them to build up their confidence and skill around providing autism diagnosis and helping them see what other partnerships they could develop with allied health or with paediatricians in their local area. And I've forgotten the second bit of your question was primary healthcare providers. So not sure in your context what that means, whether you mean GPs or, but the external partnerships were what we consider our first level contact, which is community health centres, were a key partnership. In regional areas, it was often relationships with private practitioners. They became the partners because they were the service providers that were available in local areas. Thank you.
Okay, a huge thank you to all of our presenters this session. I think it was very informative, and I hope that if any of you do have any questions, you feel comfortable in approaching and having those discussions outside of this room too. So I do believe we have a mindfulness session that's happening at the moment, but we're also, this is our designated time for lunch and also to have a look at the poster sessions as well. So I won't keep you any further, and thank you all for your time and attendance.